Respected chairpersons, members in the audience, good afternoon to all. The case I have over here is, there is nothing extraordinary about this situation. It's one which most of you have already seen, but I'm presenting this with a view from the histological perspective because we have come across very salient features in the histopathological examination of this particular case. So that is my objective of presenting this case. Now, what has actually happened here is that a 23-year-old primary female, she had come for to be admitted for in spontaneous labor, and the doctors, when they did a pervaginal examination, there was a rupture of the amniotic sac, and there was staining, meconium staining of the amniotic fluid. And meconium staining of amniotic fluid is a very good indication for doing LSCS. So in the night time, they performed an LSCS and they delivered a healthy female child who was apparently healthy at that time, 2.7 kg healthy. But very soon enough, the baby develops features of respiratory distress, and they made a provisional diagnosis of meconium-stained, amniotic fluid, meconium aspiration syndrome. So that was their provisional diagnosis. And the child developed all the features of respiratory distress, reduced arterial oxygen, chest retraction, and so on and so forth. And the very next day morning, around in the early hours of the morning, the child expired. And now the question is why exhumation was done. So the child dies, it was actually disposed, and they buried the child. But there was an untoward comment from another doctor, which I would say maybe a careless comment or an unwarranted comment from another doctor in another hospital, that something could have been done so that the child could have been saved. So that was the reason why exhumation was done, because there was allegations of negligence in this particular case. And we did the exhumation 2 days later. That is, the child dies in the morning, in the early hours of the morning. 2 days later, myself, along with Dr. LEKSHMI and Dr. JANAKI, we have done the exhumation together with the postmortem, and external autopsy findings, nothing unusual except for the fact that there was no rigor mortis, and there wasn't any visible signs of decomposition externally, except rigor mortis had completely passed off, and all the other findings for that particular age, because we had a crown heel length of about 49 centimeters, and all the other signs, indicating that particular level of maturity and intrauterine age was very much there. But the internal findings then pointed out that there was features of more or less of an unrespired lung, where the lungs were reddish brown, they were heavy, they were they're not at all crepitant, and they were in a collapsed state. The margins were sharp, and of course we did the hydrostatic test, and all the bits, they were found sinking in water. And again, one of the findings that we noted in the brain, of course, due to the passage of time, there was some amount of autolysis and there was softening in most of the organs, but very characteristic softening was noted in certain areas of the brain, especially in the regions of the basal ganglia and the upper brainstem, which we discerned. And of course, we sent all the tissues for histopathological examination, and we actually did not expect any particular finding. But again, our professor and HOD of pathology, Dr. N.S. Prema, she called me one day and said, "Hey Renju, there are some findings in this case," and they came across this presence of squames, fetal squames, which were stained basophilic. You can see those. It's not there. Sorry. Those bluish staining material, those are actually the fetal squames, which you could see packing almost all the alveoli, which were again in a collapsed state, and there were some pulmonary hemorrhages at the same time. Another important finding which they found out was the presence of Purkinje cells. Purkinje cells are usually flask-shaped cells seen in the cerebellum. In this particular case, they found that the Purkinje cells, again shown by the arrows, were, they were shrunken and they were flattened. And Madam said that she's actually seeing this in this kind of a finding for the very first time. She had to do a reference, and she came out with this finding, and it was entirely surprising for the histopathology team as well. And again, we gave the opinion based on these findings as consistent death due to meconium aspiration syndrome. Now, coming to the discussion part, what is meconium staining? You know, meconium staining, you all know that meconium is the excretory product that is contained inside the excretory system of the fetus. It usually does not come out into the amniotic fluid, but in about 8 to 20% of cases, there can be a leakage or there can be entry of meconium into the amniotic fluid producing meconium staining. And what are those predisposing factors, or what is the pathophysiology is that the anal, the rectum, the sphincter loses its tone due to in utero hypoxia. That is one reason. Second reason is that any compression of the cord or the head can produce vagal stimulation. And number three, and one of the important factors is post-maturity. In a case of post-maturity, there can be a very high levels of mortallin. Mortallin is usually, regulates the peristaltic movement. So all these factors can actually produce, entry of meconium into the amniotic fluid, producing meconium staining. And there are certain risk factors also. There was one particular risk factor in this female, which I'll tell you in the end. So there is either maternal hypertension or diabetes, chronic respiratory diseases, cardiovascular diseases, cigarette smoking, so on and so forth. Now the question is, what is meconium aspiration? So we have seen that meconium leaks into amniotic fluid producing meconium staining. And this meconium, in about 8 to 5% of infants born through this environment containing meconium has a tendency to aspirate it. So the meconium gets aspirated into the respiratory system, and then what occurs? As you all know, it can produce a physical blockage, right? If it's producing either a partial or a complete blockage, number one. Number two, it is potently inflammatory and can produce widespread inflammatory features, including vasoconstriction, and can lead to pulmonary vascular hypertension also. And again, if the child survives, it can lead on to pneumonitis and pneumonia. And clinically manifests with progressive and worsening respiratory distress. So that is all that I have to present here, and that brings me to the last slide, and I place on record my profuse thankfulness to Dr. Padmumar, our principal, and also Dr. Prema NS, head of the Department of Pathology. Thank you. If you have any questions, you can ask me.
Specific question as to what should have been done to save the day, and how
yeah.
answered by
No, that is a question which is quite important, is whether proper steps, is that what you're whether proper steps. Now we have gone through the case record, and there were some steps taken, including suction, oxygen inhalation, drugs, antibiotics, etc. were given. But I wouldn't comment on whether there was any deficiency of medical service or any negligence in this question. This has to be answered by the pediatrician or the neonatologist as well. But again, let me tell you that meconium aspiration cannot always be saved, because it depends on the extent to which actually meconium goes into the respiratory passage. If a large amount of meconium goes into the terminal passage of the respiratory passages, then it becomes almost impossible to save the child using suction and other methods. I hope, Krishnan, yeah. Thank you, sir. Thank you.